Habari za asubuhi na karibu kwenye jukwaa letu la ugharamiaji endelevu wa huduma za afya. Ninaitwa Alice Lang, mimi ni mshauri wa mifumo ya afya kutoka USAID. Nina furaha sana kuwa hapa leo na ninatarajia majadala mzuri. Bado najifunza Kiswahili, naomba nibadilishe lugha kwa Kiingereza sasa. Asante. Welcome everyone to our session on sustainable financing for health. Government of Tanzania representatives, development partners, civil society, faith-based organizations, private sector. Welcome everyone. I'd like to introduce our esteemed presenters and panelists for today. From the Ministry of Health, Lusajo Ndagile, Assistant Director of Policy and Planning. From Polra, Dr. Ntuli Pagolongwe, Director of Health, Social Welfare and Nutrition. From WHO, Max Mapunda, Health Economist. From USAID, Godfrey Nyombe, our Health Systems Team Lead. From P4H, Cookie Tarimo, Health Financing Advisor and P4H Control Focal Person. And from the World Bank, Miriam Ali, Senior Economist. So to get going, we are going to start with a presentation from Mr. Max Mapunda to set the stage for us on sustainable financing for UHC. Max, you're welcome.
Thank you very much. As you have correctly introduced me, I'm Max Mapunda from WHO Country Office. For many of you, I think you know me as a person who have been working in this in the health sector, and in particular health financing for quite some time. Now, I was requested by the organizers to start these discussions. I know it will be very lively and very interesting. And I look forward also to learn more from you than actually what you will get from me. The next slide. Yes. When we talk about sustainable health financing, we would actually like to add another word there, not only sustainable, but fair. And in my last slide, I will talk about fairness and what it means to be fair. Now, what is sustainable health financing? This can be described as a system that meets the health needs of present without compromising the health of the future generation. Now, where did this concept start? I think we all know the idea was long even before 2010 during the World Health Report, but it became very prominent in 2010 and the concept of universal health coverage. This approach combines normative goals that are embedded in the concept of universal health coverage, as I've said, and as you know, the universal health coverage has 3 dimensions, the famous triangle which we know. But today we are going to discuss one dimension, which is financing, because of its effect on the access of health services. So before we embark on the subject itself, I think we need to gather some facts regarding Tanzania. And I'm sorry, I'll be using a report of 2014-16, 2017-18 national health accounts. I'm aware this report has been updated. Ministry of Health has information, But as far as it has not yet been released, I cannot share that information now. So I will use the information which is available and which most of us have. Next. Now, first when we talk sustainable financing, the first thing is the financing itself, is it there? Because you cannot talk sustain while it is zero. As we can see, the financing is there, and in this first figure, we are showing the shares, not figures, the shares. In terms of shares in Tanzania, during this period which we are talking about, we see domestic financing growing from 59 to 68%, foreign going down, a little bit going down. But in totality, we see an increase in funding. Now, this is important in terms of when we talk about public finance and donor fundings. We consider this to be public financing. And for universal health coverage, the most important financing which can be very helpful is public funding than private funding. So it is important to note the increasing share of public funding in the health sector. Now, if we go into the share slowly, we find that government also share has increased from 39 to 45. We also see health insurance increasing. Out of pocket, we see it decreasing. And donor funding is also not increasing, it's actually reducing. So increasingly, tax financing becomes dominant. And that is important. Next slide. Now, if we look on the absolute numbers, the figures, because the shares sometimes doesn't reflect the amount. So in terms of the amount, we also note domestic funding increased between the years under question by 58%. Foreign has increased by 8%, although we notice that the share was actually declining. But in terms of the amount, it has increased by 8%. But more important, tax-based financing has increased by 114%. Now, some people would say, but we are looking on public expenditure reviews, and we see the proportion of the government budget to the health is stagnant or is even going down. But here we are talking about the amount of money, nominal terms, it has increased. Health insurance as well is increasing, and out of pocket, we see that it's going down, but it is still at a very, very high level, because as the figures shows us, it's around 22-25% being out of pocket. Donor funding also has increased to reflect the one which I presented before. Next slide. Now, as a share of GDP, for almost 3, 4, 5 consecutive years, it has been around 4 and 5%. According to the literature, it tells if the share is 50 and above, there are some elements of equity in that health systems. So these figures are giving some bright future. Now, the share of government health spending in total spending, it has increased by 10%. So these are some of the selected indicators. Next slide. Next slide, please. Now, unfortunately, in terms of disbursement, the increase, as I've already mentioned before, but in terms of disbursement for government budget, we note that whatever is being approved is not disbursed 100%. For the years which we took the budget speeches, we can see that it was actually disbursed by 57%. But we also notice, as I've said before, the declining out-of-pocket expenditure. These are some good indicators towards universal health coverage. Can we move to the next slide? Now, the observation which we see, first, there is still existing gap in financing. The report shows us that per capita spending on health was $42 and $45 for the years which I have quoted there. Now, the recommendation which we get from various institutions, and I think these recommendations started with the World Bank report, then WHO report, macroeconomic report for WHO, then high level. Those recommends the figure to be around 60 to 80. So $45 is a financing gap, is a gap. So that one we need actually to note as we were talking about fair and sustainable financing. But we are seeing continuously public funding increases. These are shown by the reports of the National Health Accounts, as I've cited. And even in those reports which Lusajo the figures which he has very recently, which I know, there are increases in public spending for health. So it's good. But another observation is that there is a draft health financing strategy which outlines a path in investing on health financing to achieve universal health coverage. This strategy was 2016 to 2026. It's almost coming towards its end, but it has not been approved. It is still draft. But some of the measures have been implemented, and I think you are all aware of the draft Universal Health Insurance Bill, which was tabled to the Parliament. These are attempts to implement some of the strategies which were outlined in that strategy. So a path towards universal health coverage in using health financing is there. It has some weaknesses which needs actually to be addressed, but at least the route towards universal health coverage through that dimensions of health financing is there. Next slide. Now, what actions do we need to do? One is to advocate for more public funds. And these public funds, they could be taxation, as we have said that when we look public expenditure reviews, the share of health is still low. But the commitment of the government we see, and I think the recommended share of 15%, that was actually to make government more committed to health. But if you put those shares to all sectors, you are in trouble. But what is requested there is government commitment. Then the other thing is actually to look on the ongoing actions towards universal health insurance. And we must commend actually the government for the change which they made. Originally, they had proposed some different pools, but I think later they changed the course and to have one pool. And we emphasize on one pool because the insurance needs to address the needs of the people irrespective of the payment. So one pool is much more preferable than actually having a multiple pool. Say you have a pool of community health fund, a pool of national health insurance fund, a pool of optional members. I think these pools will not actually meet the universal health coverage as we are looking forward. Then strengthen health budgeting, execution, planning, monitoring, in short, public financial management. You will recall that I gave figures of what was approved and what was disbursed. If disbursement does not actually go to what was approved, then you have interruptions in funding the healthcare. So that one needs actually to be emphasized. The other thing is to carry assessment. You know, when we talk about financing, sometimes when people, they put themselves only in revenue raising, that is health insurance. But financing is much more broader than that. So there are functions which are to do with the health financing, and these are revenue raising as one of which we normally talk about. But there are also issues of pooling, as I've said, purchasing, benefit design, and rationing. Constantly, country needs to make an assessment to the functions, these functions of health financing, to see where is the problem, where you can rectify, and then it will help you to move forward with the idea of universal health coverage. Next slide. Last but not least, I talked about fairness, and this is very key, that the health financing system, which we think is ideal for universal health coverage, is that one which allows individuals to access health services according to their need and not according to their ability to pay. I thank you. Next slide. I thank you very much for this. I hope I've generated discussions which will be lively. Thank you, Alice.
Thank you very much, Max, for that overview. I'd like to invite Lusajo Indagile to present the vision for the Ministry of Health.
My name is Lusajo Indagile, Minister of Health. I think my concept of healthcare financing. So for me, I can just explain where are we coming from and where are we now. If you go back 60 years back, the healthcare financing in Tanzania, if compared to now, they've been changed. Around the 60s, there was talking about the free service to the society. And later we come 90s, we introduced the cost sharing, and then we include the issue of for those who cannot access this. Coming to 2000, early 2000s, then we came with the idea of payment. We consider the issue of prepayment. So if you consider all those errors, the motive was to strengthen the provision of health service from cost sharing up to service. So that's why today we are talking about the bills. In the 2015, the government started to think, especially on the concept of pulling the resource together. What are the best mechanisms to collect all the resource? So we think out now, at least we need to have the mandatory health insurance, whereby most of the old population should be covered with the health insurance. And this was based into the study which conducted from 1994, especially when we were introducing CHF, and then the other healthcare financing study taking place in 2010 up to 2015, Currently, they see the only mechanism of supporting health service is to have sustainable financing. So that's why now the government is in the process of developing the bills. We are aware it was last year whereby the bills was tabled to the parliament, there are a number of issues raised. But the aim was to make sure people they've access the service without financial hardship, because we know most of the population they suffer from economic hardship. As I was speaking, the population covered with insurance, we are talking about only 15%. So if we talk about 15%, comparison out of 100, you can see there are about 85% are not covered with insurance. And we are experiencing the era of whereby the number of disease, and then people, they want to access the service, they don't have the resource. So I'm trying to explain where are we coming from and where are we now and what are the direction of the government. That's why we are here, making sure that we are going to implement the universal coverage. As you can see, that some investment have been taking place with the government. The aim is to reduce the fragmentation of the resource. Max Bakunda mentioned we have challenge of out-of-pocket. So the only mechanism is to having mandatory health insurance. We have national health insurance, we have CHF for the informal sector, we have private insurance. All those are trying to address the issue of sustainability financing of the healthcare service. Thank you.
Thank you very much, Usasha. So we're going to continue on to our panel discussion. We want to talk about, what is being done to support domestic financing initiatives for health in Tanzania. And as we heard from Lusajo, the government of Tanzania has a goal of reaching universal health coverage and really ensuring that every citizen has access to quality health care. But there's still a long way to go. So I'd like to ask our esteemed panelists about the current initiatives and opportunities for sustainable financing, including but not limited to domestic resource mobilization and improved efficiency, such as public financial management reforms. So I'd like to start off with Max Mapunda from WHO to ask about, given where Tanzania is now on its path to universal health coverage, what do you see as the main challenges and opportunities for improving access to healthcare for all?
Thank you very much. I think there are more opportunities, and over recently you have noticed an expansion of primary health care facilities. The government is expanding primary health care facilities. These are opportunity to increase the access in terms of services. But the challenge which is clear is the functional accessibility of these facilities. That these facilities, sometimes they lack resources to be fully functional, no inputs to run them. And this is a challenge. And I think government, when it's making all these efforts, is trying to make this functional. Because if they are not functional, then achieving universal health coverage is a big challenge. Then, remember when I was talking about the per capita spending, which is very far below the recommended levels. But I think for some of us who have background in economics, we know that you cannot satisfy everything. You cannot get everything. So with that little amount of money, I think government needs to look more on the issues of efficiency. Unfortunately, I did not have access to some of these studies of efficiency, I would have shown. But we know from literature, investing in primary health care is much more efficient than actually tertiary health services. So these are some of the challenges which actually government needs to look at. And efficiencies are looked actually on two dimensions. They are allocative and technical efficiency. Good thing with this government, they made a lot of studies and trials. And some of you will remember Tanzania Essential Health Package program, which was actually encouraging, with the little money you have, to choose the most cost-effective interventions. So these are the areas which government can think about when it talks about improving efficiencies. Last but not least, to give time to my colleagues who are also contributing, it's the issue of fragmentation. I talked about pools. There are so many pools right now. We have government pool, we have national health insurance pool, we have community health insurance. So these pools, first they are disaggregating people not to achieve services according to their needs. So these are some of the challenges actually which we need to address. And I know government is, the process towards establishing universal health insurance is actually towards that direction. So we will encourage government to move towards that direction. Thank you very much.
Thank you, Max. So I know Lusajo and Dr. Njuli are probably eager to respond to those questions. But before we get to that, I'd like to ask Miriam from the World Bank if she could tell us a bit more about how the World Bank is supporting Tanzania to improve access to health services for poor and vulnerable populations, recommendations you have for improving equity in health financing.
Hello. Good morning. Good afternoon. I think it's good afternoon. Thank you so much for inviting me to participate in this session. And we agreed because the session aligns very well with the World Bank twin goals of reduction of poverty and shared prosperity. When you talk about access to the most vulnerable, you're talking about the people who we care most, whom the bank is established for them. So we really, the topic aligns very well with our objective. Now coming to what bank is doing, bank, as we all know, is a knowledge bank and is also financing bank. So in Tanzania, we are doing the same. We are supporting the government together with the other stakeholders, developing products, knowledge, studies. We have been supporting government in various studies, health financing. Recently, we released a report together with the government on pharmaceutical production. And I'm really glad that we are going to, it's really moving up and implementation is coming. We have been supporting government in pandemic preparedness studies. And most of the studies, to be frank, have been informing policy, our policies. For example, when we are starting DHFF, when we are starting, we are doing the UHI, we are starting the rally because it's almost 10 years. A lot of studies which have been supported and have been informing the government and the other stakeholders. So that is one area. Second area, bank is also financing, is giving finance, and the comparative advantage of the bank financing is that first, it is disbursed, spent, designed through government systems. The bank uses government systems to deliver our support. In Tanzania, over many decades, I think 2 or 3 decades, bank has been supporting, focusing on primary health care. We have been supporting primary health care because that is the most cost-effective, most efficient interventions that can bring forth big outcomes. In the previous project, the last one, we supported government and we had measurable and really promising results. One of the things we are happy and proud is we actually bank started the initiative of renovation and construction of PHC facilities. We started with 100 facilities and government themselves did it. And one of the things we are happy is the capacity built within the government to design, to supervise, to also make sure that these things are functional. We are saying that because through this initiative, government has now a guideline of how you can do it. That's how a bank works. We are happy because not only that they did construct, but also services are delivered. In these facilities, C-sections have started about, in our last report, it was 100,000 people have received services. The other thing is on the performance. Our bank has moved towards performance financing. We used to support, we used an instrument called IPF, investment financing, but now we have moved to performance programs for results, whereby we agree with the government. And this is really encouraging because it builds the capacity of the government to supervise, to plan, to implement, and to supervise themselves before it comes to the bank. And this, when we talk about efficiency, when Dr. Mapunda was talking about input, output, the technical efficiency, and even allocative efficiency, I think these are the things which put the government into driver's seat to implement, because they have to earn money, they have to produce results, they have to put systems like Internal Auditor General, the one who is now verifying within government systems. Bank is just outside supporting together with other partners. We are happy through, again, bank support, Health Basket Fund. We introduced allocation formula, which is performance again. Equity-based, part one, but also performance, to make sure that those who perform, those who really deliver services, they get the money. Because some facilities, it's not by design, it's not by, but maybe it's not that they are not working hard. It's just by design. Maybe the way they are located, they don't have enough patients. Why do you give them equal amounts? So we have introduced that, and we believe that government is happy and proud. That's why they've introduced it in the DHFF, and they are now moving forward to review formulas. But we are happy that performance elements are in there. Okay. Oh, it was wrong to look at you. I was supposed to look that side. So with the bank, those are the things we have done before. But now, currently, we have a very new project, which started this July. This project, it is also still focused on PHC, 5 years project. But one thing which we think is new in this project, we are focusing on bridging the gap from the PHC to secondary care. Because most of our services were focusing on PHC, but we realized, especially for women whom we care most, when they are referred to district and regional hospitals, the capacity is not there to receive them. So that is one area that we have introduced, but also to scale up government initiatives. Bank is good at that. We are now going to work with government to make sure that we implement a emergency transport system, but also most cost-effective intervention. We are going to work together with the government, but in a performance-based approach to finance community health services. We are going to use government systems to pay CHWs, whom are really very crucial in the service delivery. They are most cost-effective persons who detect early diseases, help people to attend and access preventive services. We all know that. So that is the area we are now going to support. Thank you.
Thank you, Miriam. I'm going to pass it over to Lusajo. You spoke about the government's vision and work towards universal health coverage. I wonder if you could speak more about the main challenges to funding quality healthcare in Tanzania and the current opportunities, and perhaps speaking to some of the points that we've heard from Max and Miriam about efficiency, fragmentation, community health workers, performance-based financing, etc.
Thank you, moderator, for this opportunity. So for the case of the challenge, is it? Challenge and what are the opportunity? I think one of the challenge, fragmentation of the resource. This can be, we not all talk about for the health insurance, but also in the mechanism we use to fund the health sector. For instance, you can see most of the resources are allocated through off budget. And some of them, they are channeled through the government system. So sometimes it became challenge how to track. We know we are doing stats, we have some of the system, but it becomes difficult to know how much you have because some of the funds are going direct to the projects. So it takes time to get the information. So that is one of the challenges we experience. We have the system, DHFF, and to improve financial management. I think if we comply with the government system, the issue of sustainability will be addressed. I remember we did one of the start with the support of partner, but the data show there are a lot of the resource go to the project instead of coming direct to the health sector. Because as a sector, as a gap, we have the priority. So sometimes we compete within our priority. We allocate the funds from one of the areas and you find the other partners support those areas. So why can't we sit together? No, but maybe let us harmonize those. Apart from that, another challenge I already mentioned before, the issue of out-of-pocket. It is a dictum that it's not at a reasonable, because at least we need to reduce the out-of-pocket. So in terms of what are the opportunity, I can just list some of them. Number one, government commitment. That's why here we are talking about the bills. The government is high committed. We are going to implement the universal health coverage by finalizing that plan, because we know most of the people, they are not covered with insurance. Apart from one, we have the improved financial management. Now we channel the funds through DHFF to the facility, especially basket funds, that we are seeking even other resources should be channeled the same to give autonomy to the facility. Another, in terms of infrastructure, we are doing well. I don't need to mention, but all of us, we know there are a number of facilities from primary levels up to the national level. Almost, we have strengthened the regional referral hospital, national hospital, zone hospital, even to primary level, by equipping them and even providing human resource for health. We know we have shortage of human resource for health, but at least we are trying. That's why we are coming the program community health work, at least to reduce the existing gap of the health sector. Apart from that, also we have the issue of quality of service. We are trying a lot. There are a number of improvements have been done. Current at the regional level, the focus is at least to have the specialized service where previous could not avail those services. We just get from zone hospital up to national level. But now even the regional level hospital have the super specialized service. Sometimes even at the district level, we have some of specialized service there. When you talk about the health commodity, a lot have been invested. If you go through the budget allocation, especially for this commodity, for the consecutive more than 5 years, they've been increasing. Today we are talking about, for essential commodity, more than 200 billion allocated for this commodity. Those to ensure at least to improve the quality of service so that people can access this commodity whenever they go to the facility. In terms of information technology, we all know we are now talking about telemedicine as a mechanism to address the shortage of resources for health, but also to improve the use of the system. Nowadays, we are trying to connect the national hospital with the regional referral hospital with telemedicine. Nowadays, you can get the service, you're in Mbeya, you're in Tanga, wherever. You can contact the people from Muhimbili, from Moi, do consultation, and where need arise with the referral, then you can be sent to the national level. But at least we are trying to solve the issue of resource for health, but also to improve the quality of service. Another area, in terms of preventive service, a lot have been done. If you could see the coverage for vaccines is more than 90, according to the stats we have. Even the area of mother and child, a lot have been done. We have CMOC and others facilities. In terms of, so those are the commitments as now for the government toward the universal health coverage. But the most important things in this forum, I think all of us together, we need to see how to comply with the government system in financing the health sector. If we concentrate on looking at least people, they need health insurance, where we allocate resources at the different mechanism, I think the issue of sustainability will be a challenge. So I think all of us together need to see what can we do. We are talking about the health coverage. Do we our resource following the government system? If not, what can we do? Thank you.
Sajo. So, Dr. Ntuli, could you tell us about the work that POLRUG is leading on improving allocative efficiency in service delivery and public financial management? What more is needed?
Thank you very much. Thank you very much. I think it's been spearheading the issue around the efficient public financial management. And we have had a number of reforms, but the notable one is of 2017 when we did introduce the Directors Facility Financing. And through that arrangement, what we have seen, there's a tremendous improvement in terms of our quality of services rendered to the people. Because we did the before-after study to compare a number of our indicators before the introduction and after the introduction. And what we have seen is quite very clear that after the introduction of the direct facility financing, we were increasing the efficient use of resources, but at the same time, we also witnessed the improvement number of maternal newborn indicators, the supply chain management indicators, also the financing indicators. So this is one of a very important initiative as far as the allocative efficiency is concerned. But apart from that, we worked with the World Bank to improve the resource allocation formula so that to make sure that whatever resources which we are dispersing to the lower facility level should be able to take into consideration the issue of equity. Initially, there were some of the things which were not taken into the formula, but later we had to introduce, including the issue relating to hard-to-reach areas. We have some of the districts in the country with many islands, including the Ukerewe with more than 38 islands. So we had to separate this council to the other councils to make sure that we allocate the resources effectively. However, I must admit that one of the challenges which we have experienced is how do we take care the implementing partners. Usajo said, part of it, we have two main arrangements for dispersing resources to the lower level. We use the exchequer system, and also we use the direct-to-project funding. But we have some other partners who are swimming in between. So they are neither on the exchequer system nor on the project direct funding mechanism. And this is the tricky part. We need to get hold of these partners to be able to track their resources, to know how much do they contribute to our primary healthcare system in the country. So there's a lot of duplication. You might find there are 3 or 4 partners doing the same thing with the same amount of resources. So compliance to the government system is quite key if we were to sustain the healthcare financing. Otherwise, if there are people who want to be complying, then it will be very difficult. We have had a number of systems now. We have the financial tracking system, which is called FAS, Facility Financial Accounting and Reporting System. It's working pretty well. But we need all the people to be in that system. Because with that one, that system, you can have a real-time information of more than 6,500 primary healthcare facilities in the country. But we need everyone to be on board for us to be able to track all the resources which are for the health sector. That's one. But the other thing is we have to make sure now, whatever penny we are putting from the health sector or primary health should translate into quality. But we have seen a number of quality indicators which we chose. We've been following them through for the past 5 years, and they're working pretty well. So we need to keep on putting money for that. And I must say that primary health care is a strategic area for us to change everything. Everything is happening at the primary health care. So whatever investment we'll be doing, let us go to the primary health care. With secondary, tertiary, they are far better as compared to that level. We need to have electronic system. We need to digitize the primary health care. So I'm going to use this platform to call for partners to work with the President's Office, local government, to digitize the primary health care, to digitalize the primary health care. In so doing, then we shall be very sure whatever money which goes down, that we have some return on investment. So this is what I wanted to contribute, but again, maybe to add on what Mariam said, we are slowly moving from input-based financing to performance-based financing. With World Bank, we have divided our resources into the base tranche, and then we have the performance tranches. And it has motivated our facilities and our colleagues, the frontline workers, to really now focus into putting much of the effort to improve the primary health care. So I think that should be the move. Slowly, we should move from the input-based to the performance-based. So I'll stop there, but otherwise, we need support from different stakeholders to work with us to make sure that the primary health care are well financed, and whatever resources which are directed to the primary health care should be effectively used. I know with the system which we have, we need to optimize them so that they can efficiently give us the good results. Thank you.
Great, thank you, Dr. Njuli. So that's a good segue to our next main question. So as we think about development, one of the goals is really to gradually shift priorities and adjust resources to support country priorities and government priorities, and for the government to really take full ownership and stewardship of all of the activities in the country and the health sector response. And so as the Tanzanian economy grows and development partner funding stagnates and declines, what progress have we made towards streamlining development partner funding and managed initiatives to the government and local organizations? And what can we really learn from these experiences? So I'd like to pass it to a colleague, Godfrey Nyombe, to talk a little bit about what USAID has been doing in health system strengthening and about institutionalizing systems and support of government stewardship.
Good morning, it's still good morning, few minutes to morning. Thank you for, at least for the question and the distinguished panelists here. Just to really appreciate the stage that has been put down by my former speakers here, and really saying about what USAID focus on the areas of sustainable financing. USAID Health Systems Strengthening strategy really focused around three main priorities: quality, equity, and resource optimization. But for this case, I think I'll focus more on the resource optimization. This is where I think most of the conversation here has been also really focusing around how can we have more efficiencies? How can we support the government to have more efficiencies around all the resources that are pulled out into the health sector? And within this, I think Max has also mentioned earlier, one of the priority area of where we can have a great win is through the execution, monitoring, and tracking of resources. And I think that's where the PFM work of USAID really is really focused on. A lot of the work that we have worked with the government, Ministry of Health, and PORAC, together with the World Bank as well, has really focused on strengthening the public financial management systems. And that has been, I think, a critical story, and actually adding to what Ntuli was mentioning earlier, that we wanted to create more confidence to the public financial management system. So to allow the challenge that I think he just mentioned on donor-funded and other donors to contribute through the government system, using the confidence of the PFM systems that are strengthened. And that's the fact why we started, I think, around 2017-16 to support the government through the planning processes, from planning and reporting systems. The PlanRef system came into action, and now it's scaling beyond health, and everyone is using the automated system within the government systems. And we are happy some of our partners are already using those systems to actually put their interventions within the PlanRep system. But also looking around now, the DHFF money going down, we went further into the PFM system, supporting the government as well to the FAS, the Facility Financial System, very government-owned, and actually at the moment, we're supporting the government to move it further to the village level, to the community level, where there's some community interventions that are happening there. All of these add up together to what I think we really aim to have: all resources tracked and be able to really be efficient in how we are optimizing the resources that are there. And a little bit touching into the human resources, because it's a financial component of human resources as well. USAID is also trying to use the same aspect of optimization of resources and efficiencies to try to help the government to optimize. We may not have all the human resources that are needed right now. We're at 65% of shortage. We may not get there, but whatever resources that the government may have, whatever healthcare workers that the government may have, including our projects and activities that are working on the ground, how can we optimize and make sure that we're allocating workers where they're mostly needed and where we can really see the impact of service delivery? So I think that, to summarize, is the area where we're really looking forward to continue working. creating more efficiencies, creating more optimization, and be able to strengthen the existing systems in the PFM, and that's how we can really create the good ground for universal health insurance when it's ready. Thank you.
Thank you, Godfrey. So I'd like to continue on to ask Miriam if she could tell us a little bit about how, the fact that you spoke before that the resources move through the government system. What have you learned from this experience, and what would be your call for their development partners?
Thank you so much. Just quickly, what we have learned so far, one thing is we have great counterparts. We have great counterparts. When I say counterparts, I mean government colleagues as officials. They are ready to cooperate, to work together towards agreed objectives. These reforms we are talking about, they are not simple. They are really, you need to take risk as a manager in the government. But these people we have been working with, PRH, Minister of Health, Minister of Finance to start with, because they are the ones who always give the green light. They are very good and willing and ready to work with us. And that's really a positive, because without leadership from their side, it's very difficult. The other thing which we have learned is that since these reforms are critical and complex sometimes, it's easy when you work and use the reform. Should I be more specific here, Geoffrey? Will you be offended? You can, for example, when you develop a system as good as FAS, and you don't use your resources, sometimes it gives some question mark to other partners or even to government. But when you introduce a reform which is complex, that was just an example. But there are many other reforms which are very complex and sometimes risky. But if you use your resources to implement that reform, it gives them confidence that nobody wants a loss. So if you are ready and willing to use that to introduce the reform using your money, it means you are confident with what you are introducing. Also, being a bank with many countries, bringing experience from elsewhere has been very useful, and the government of Tanzania has been very receptive to learn and to adapt. The other thing is capacity. When you use government system, you build the capacity I don't need to explain that much, but capacity of institutions first, second, individuals. When we talk about institutions, I remember when we started the first project, everybody was cautious to use internal auditor general to verify, conflict of interest, their capacity, everything. But we said, no, this is what the government has. We are going to equip, we are going to capacitate them. And now you can't believe it, almost everybody wants to use IAG. So capacity, and these are lasting institutions. I underline lasting. Bank project will go, Mariam will go, but IAG will remain with that capacity to help the government. Need to speak. I don't want to talk about the other side. What is the message I give to others? I think that is beyond my pay grade. But let me give my experience working with the government. And it has been a pleasure, to be frank.
Thank you, Miriam. So I want to ask Lusajo and Dr. Ntuli to reflect on what we've heard from Miriam and Godfrey about the initiatives for institutionalization and capacity development, and really shifting as much of the resources as well as the ownership, really full ownership of the systems to the government. What lessons are we taking from that, and what more do we need to do?
Governments needs partnership, meaningful partnership, and we have enjoyed with the World Bank, with the USAID and the partners. Some they assign the expertise or the experts to our department to work with us, of course with the World Health Organization. So we have enjoyed in that area. But importantly, I think is the knowledge transfer now after the assignment. When the teams, especially the indigenous, when they continue with what they've been capacitated with, this is something which we usually value a lot. But adding to what Mariam has said, when it comes to the reforms, there are two types of reforms. We have the minor reforms, where you do just some small adjustment to a program or something like that. But with major reforms, really, that's a huge risk when you go into that. So you need different stakeholders to work with you, to support you. One of the major reforms, I must say, it was the direct facility financing, or the FAS. Most of the people, they were very much skeptical. They were not sure whether the money would be safe. And when we started with the measles rubella campaign, money being dispersed by WHO by using that arrangement, so everyone was happy that, oh, the system is working. But when we started, it was not easy. It was not easy at all. That's why I'm insisting that if we are to move forward to have sustainable financing, everyone has to comply. That should be the first step. But secondly, is to make sure that whatever we are doing, we should embed it with an implementation research. We need to learn scientifically whether the initiative is working or it doesn't work. So research cannot be left behind. It has to be part and parcel of our every undertaking, so that we can scientifically learn whether an initiative is working or it doesn't work. Then the last thing I think, which is most important, is to always come up with another set of reform. Reform is an ongoing process. You cannot do it once and then you stop. You have to do it on a regular basis so that you can improve. And we have learned from the 1994 health sector reform, and then 1998, and other ongoing reforms. You usually build from the previous ones. So I think that should be something every one of us should take back home, that reform is something that has to continue all the time.
Okay. I think most of them Dr. Antoli mentioned. So maybe I can just say some few things basically on question raised. Number one, we appreciate the working with the partners, because in any development, teamwork is required. As a government, we also need to work with the partner. As we are aware that here we are discussing the issue of healthcare financing, we know now the direction is going to have universal health coverage. Their resources are going to be required to implement. So it's the higher time for the partner to see how they best can support the government toward the implementation of universal health coverage. We appreciate the number of partners who will continue supporting, technical support, and even financial. So I think maybe let us focus on those areas to see how the best we can implement the universal health coverage. For instance, now we are talking about it's mandatory. So how we are going to finance the poor? We are talking about 26% of the Tanzania, they cannot afford to cover for themselves the health insurance. So who can finance? We know the government finance, but also it's the higher time for the partner to see how they can support the government. Because if we just insisting mandatory insurance and you know people, they don't have access or they don't have resource to pay. So I think we need to discuss together and to see how the best we can support the government. Not only that, We know approve the bill is one thing, but the implementation is another things. The number of institution arrangements should be taken place. Also, we need to support those areas. Capacity to train. Dr. Antoli mentioned about the research. That's very important things. These are going to be new things, the first things to be implemented. So number of research are needed in relation to our country situation or our environment. We know the other countries have been implementing risk coverage, the way Rwanda's other countries, but how best approach can be applied to our country in order to make it sustainable, especially when we focus to supporting the society, especially the marginalized society. So for me, I think that the most important things, if we get the answer for those areas on how to support, I think the journey won't be difficult. So thank you.
Thank you, Lusajo. Thank you, Dr. Antoli. So now I'd like to pass it to my colleague from P4H, Kuki. Kuki, you've heard from all of the panelists about reflections on domestic resource mobilization, public financial management, as well as opportunities and initiatives to really improve institutionalization of certain systems. Could you tell us, given where your work with the government, both on mainland and Zanzibar, now on this path UHC, how do you think that the government of Tanzania and development partners can best contribute to improving domestic resource mobilization?
Thank you very much. I'd like to think that the good thing is in Tanzania, we have actually the framework, which is the instrument under the Ministry of Finance, which actually highlighted how should development partners and government work together to achieve a common goal. I think that framework is called Donor Coordination Framework under the Ministry of Finance. And the good thing in Ministry of Health, we have this what is called SWAP, sector-wide approach, whereby we have these different technical working group, whereby expertise from development partners and government sit together and discuss different health issues and coming up with a common understanding on how to solve those problems. And I think over the recent year, this mechanism, especially this technical working group, have not been like working effectively and efficiently. And I think now to strengthen this coordination between development partners and government, I think now we should ensure that this technical working group working effectively and efficiently and in terms of discussing and creating this debate. The second thing maybe which I can highlight is the point of sustain and increasing domestic resources for the health sector. I think inside of development partners and the government, they should work on creating more smart advocacy to inform maybe the decision making, especially the Ministry of Finance, to understand the needs of health sector. So helping actually the side of the health sector to develop these evidence base, as Tuli and Lusajo mentioned about research, evidence-based research to show the case that we need. Because you cannot go to Ministry of Finance saying, do I need these resources, and you don't have numbers. Of course, things are, you can see in health sector that we need this, but we need to have, we need to move to smart advocacy by having this, this evidence. And also showcase how efficiently we are using. Max Mapunda talks about efficient utilization of resources that we have in health sector. So, like, we together, government and development partners should work on, like, showing the case how efficiently we are using these resources for the health sector to come up with a big, big outcome. I would like to stop there.
Thank you, Kuki. So that's all the questions for our panelists for now. Now it's your turn. So I welcome any questions from the audience. We'll take 3 to start. Okay, way in the back, I saw that hand first. Karibu.
My name is Godfrey Swire. I'm a public health student, and I've been practicing public health for the past 40 years or so. So I've had a lot of time to look into this issue of sustainable financing. I've looked at 199 countries in the world. Only about maybe a dozen or so will be able to achieve UHC by 2030. For sure, we are not going to achieve it. And for us, it will take 40 years. When I go onto my drawing board, I try all scenarios. Why? Because stunting is 30%. And if you have stunting, it cuts across old ages up to 100 years. If you have stunting of 30%, it will constrict your workforce between 15 and 64 by 30%. So that one part in supports himself plus an additional 3 persons. If you go, we are stunted by 30% of all groups, so that one person supports 4, so that it will not be possible to have sustainable finance until you eradicate stunting, which is purely nutrition and prevention. So I think we should focus that one in that direction, so that we have a workforce that will be in 30 years that can finance health, but not now, not for health insurance. It is not possible. Ask an economist. Secondly, donors finance problem. They do not finance solution. Solution must be inside. So we must have this to tell donors what they should finance, not what they want to finance. And if some countries, this is our policy, we have 207 policy. We do not have universal health coverage legislation under the policy. We do not have a research agenda for primary health care or for universal health coverage. So everybody is doing all the researches. So I think we need a policy, we need legislation, and we need to eradicate stunting. Thank you.
Thank you for that comment. In the back, please.
Hi everyone, my name is Joseph Mweshemi from FHI. Thank you so much for the presenter Mapunda and Dr. Ntuli for demonstrating the government willing for sustainable health financing. My question is on the preventative care and health promotion. To what extent are we investing in preventative care and health promotion programs to reduce the burden of preventable diseases and ultimately lowering the long-term health care costs? Or we are more fixated on health financing for the tertiary and primary health care? Just to know to what extent are we focusing on the preventative care and health promotion services? Thank you.
Thank you. My name is Rukaya Mahmoud. I think both questions will go to Mr. Lusajo and Dr. Ntuli. First, I would really like to know how the government financed, during the 1990s era, we had free medication. And what is it that bothers the government to conduct the same thing? That, okay, the population has increased, okay, but we have the population full of business people and full of taxes. So what really makes the government fail to finance healthy? But second, you were talking about completing the process of UHC. I would really like to give my opinion. When you guys are completing this thing, you should really consider on giving the services per the need and not the packages or the payments. Thank you.
Okay, thank you. At the end.
First, I want to take my mic. Thanks a lot, panelists. This was a very, very good discussion, and I must admit it's in the heart, my passion. And I'm saying that I think Dr. Ntuli is laughing because they know we've been having some coffee meeting to discuss how can we sustain health financing at the primary health care. So AMREF, with support of Irish Aid, I don't know whether they're Irish Aid here in the room, we started a project in Mwanza to demonstrate sustainable health financing for community health worker, for community health system. And one of the outcomes that we were expected, or we were to showcase, was how can the community health worker continue to be paid beyond the program using the FAST and the direct health financing systems, the DHFF. That has worked perfectly well in Misungwi, Kwimba, Itilima, and we wish that all donor funding, so we started with USAID, by the way. We have our USAID TB to also start using the same system to pay community health workers. So, of course, there are many challenges that people talk about regarding to the remotelessness of the health facility, the delays in approvals through the FAST system, which are challenging to that we can have this digitalized and have those approvals being done at the level, at the facility level, instead of the medical officers moving around to seek approval. So the community health workers are paid. So we send funds directly to the community health workers' accounts. But it is approved through the FAST system. And the good thing is in Misungwi, and you can even go and check with the district executive director, they have promised to sustain almost 10 villages that they are ready to contribute beyond the end of our project to put money for continuing payment of their community health workers. So these are very good examples that we really should work together and see why not all donors and partners are willing to pay through the direct health financing system and not sending money through M-Pesa, etc. to their account. I think that system works very well. We are championing it very much, and we wish it to be scaled up throughout the country. And thank you so much.
Okay, thank you. So to our esteemed panelists, how would you like to start? Dr. Ntuli, would you, or Mike? Okay, Lusato, the floor is yours.
Okay, thank you, members, for the question. I'm going to respond. The other Dr. Antul will add. And number one, we talk the issue why the government does not offer free service as what has happened in 60 years. In economics, we know always the resources are scarce. And there is a competing demand. I like the way she mentioned about the population size. Might not be the reason, but might be a factor because population 60 years up to now, it is increasing. But we need to see the issue of sustainability financing. That's why the government since the 60s, the number of reforms that have been taking place from free service, we moved to cost sharing, we moved to waiver, and then we moved to health insurance, and now we are going to have the mandatory health insurance. So the aim is still the same, but we haven't changed the modality on how to finance. It's not only in the health sector, but even in education sector. I remember those days, there was a free education. But now at university level, we are going to access the loan. So the important thing is to ensure the issue of sustainability of the service. That's why we are now focusing on to have the prepayment service. And also to create the issue of ownership, because if you contribute something, you create ownership of it. But also cross-subsidization. We have the people with higher income, others low income. But also the pattern of disease has been changed. Disease for 60 years to date, there are a lot of changes. So I think that the main reason. Another, you talk about the issue preventive and the promotion. We agree, if you go to the start, most of the resource allocated in creative service, it is very true. But that does not mean the preventive promotion is not important. Still, it's very important. That's why the government or the sector advocates on the issue preventing disease such as NCD. There are a number of forums. Now we're encouraging people to do exercise. Even now, if you go to the government seat in Dodoma, the infrastructure have been considered on the people they can do exercise. We are not doing much a lot, but something is happening to promote the area promotion and the preventive service. Because at the end of the day, if we invest much on the preventives, we are sure even the budget for corrective service will be reduced, because wanasema kinga ni bora kuliko tiba. So we agree, number of efforts have been ongoing. And that's why we insist people do exercise, diet, consider the issue of diet. Yeah.
Thank you, Sandra.
Yeah.
We only have a couple of minutes left, so I want to make sure we have 1 minute for Dr. Ntuli and 1 minute for Mike's response.
Thank you very much.
Thank you.
Yeah, I think maybe to add on what you just said, we follow the primary health care service provision framework, which we start with health promotion, then we go into protection. Now the WHO and American Society of Public Health, they have added the protection. It was not there before. We had just the preventive, but now we have the health promotion, protection, prevention. Then we go in curative, then continue. With the new guidelines, much of the emphasis has been put into the health promotion. But I must admit that of all these components of the primary health care service provision framework, the health promotion, it has never been taken serious by people. Most of the people whom you see they're exercising, they already have the NCDs. You do your research. And this is a new finding from one of my colleagues in Kenya who conducted a study in that the people that will start now going into exercise, after being told that you are pre-diabetic, take care. Otherwise, so that is something everyone should take it. But looking into what Dr. Swai said, the government of Tanzania is seriously taking the nutrition issue into account. That's why Her Excellency Dr. Samia Suluhu Hassan signed the performance contract just for nutrition between herself and the regional commissioners. And that has cascaded up to the community level, just to try to highlight and to make the nutrition agenda visible. We are not doing well. Stunting at 30% is not good. We have 28% of anemia as a prevalence for women of childbearing age. We are not doing well. But I think that should not deter us from continuing with some other activities. We should continue investing in nutrition, but at the same time, investing into the health. That's why I'm happy that even our department is called the Department of Health, Nutrition, and Social Affairs Services, just to make nutrition visible. But the complexity of nutrition is much sexual. It cannot be dealt with health alone. You need people from the water sector, agriculture, and what have you to work with you. And then the issue with regard to the 1990s, where we had to embark into the cost sharing and other things, that's a long history. And I will recommend you maybe to get a copy of the book which you have written. We have written it extensively to explain what happened after independence, and even before independence. That will explain a lot. So I'll get you a soft copy. With what Dr. Moya said, I must commend AMREF South Africa. They are working with us very, very, very close, and we have done so much with regard to the direct facility financing. With regard to the challenges which we are experiencing right now in Misungwi and some of the other districts in the Lake Zone, we have come up with a new solution now. It's going to be a digital one. And we have tried it with the MMAMA system. Because we had a similar challenge of getting the drivers, especially those who are owning the taxes. But with the new solution, we worked with the Minister of Health, the Minister of Finance, and the PRH. Now we are having the solution. So they can be paid via their mobile phones and also via their banks. So that will no longer be the challenge at all. And with regard to other things on universal insurance, as my colleague said, we need partners to work with us. As soon as the bill passed in the Parliament or the House of Representatives, then we'll need you partners to work with us. We need to take off now from there. So the issue at hand is to make that bill pass, which we are quite very optimistic. But again, after that, financing for the poor, it means a lot, and that is what we call leaving no one behind.
Thank you. Well, we're over, but Max, if you want to give a few words.
Thank you. Thank you very much for the student who doesn't graduate, Dr. Swai, though he was my teacher in public health. Dr. Swai, don't be pessimistic. We do monitor, WHO do monitor universal health coverage, and we produce indexes. And we find there is a relationship between income. And you know, the last when we produced these figures, it was in the brown bag meeting in WHO about 4 years ago. We were about 47%, while those countries at middle income levels, they were 70, 50. But mind you, by then we were a lower income country. But now we are lower middle income country. So that index might actually have gone up. So when we give up next figures, it will be different. And on top of the figures which I have produced here this morning, that it shows that the direction we are moving is the right direction. So don't be pessimistic, be optimistic. Thank you.
No. Maybe to add on what Mapunda said, so our current universal coverage service coverage indicator is 43%. So we moved from 38% in 2015.
Okay, last but not least, the reports which I presented this morning is national health accounts reports. Unfortunately, some of us, we don't contribute information to that report. We don't even read it. It's a very important report to make decisions on all health policies and health financing. Thank you.
Thank you. I'd like to thank everyone, our esteemed panelists, very much for participating. Thank you, audience, for your questions. This was wonderful. Thank you again for joining us. Sana.
Let us put our hands together once more time for the moderator and her strong panel, and for leading the session so ably. Asanteni sana.
Asanteni sana.
If you want to stay in Mikumi Hall, which was sold out,